Welcome to the State Health Registry's video training library. I'm Lori Summers, the trainer at the Iowa Cancer Registry. This presentation will wrap up the treatment for the colorectal cancer and also some text documentation. Here's a list of treatment fields that I will discuss. Mainly want to focus on the primary site surgery for colon cancer, but I will touch on a couple of these other fields as well. Surgery is the most common form of treatment for colorectal cancer. For cancers that have not spread, treatment is likely curative. The site-specific surgery codes are found in the SHRI Appendix C and is also found in the STOR manual. I believe it's Appendix B. Each of the sites listed here still have separate surgery codes. So the small intestine, the colon, the rectosigmoid and rectum, and the anus are all different surgery codes. These are not managed by SEER. These are college fields and college coding guidelines. So these have not changed for a while, and the location of these, I've given you the link there. Just be sure that you're selecting the correct guideline for the surgery that you're coding. When you look through the primary surgery codes, you will notice a similar pattern of codes with these surgeries for the colorectal sites. The surgery codes will describe either a local tumor destruction or removal in codes that range around 10 to 20, or a partial removal of a colon segment in the 30 range. The hemicolectomy, or half of a colon resection, is in the 40 range, and a total removal of the colon is in the 50 to 60 range. Finally, a total colectomy with removal of other organs is coded to 70. So let's just take a look at a few of the colon surgery codes. This slide pictures a polypectomy, the removal of a polyp via scope. The polyp is visualized on a TV monitor, snared, removed, and sent to the path department. This is a code 28 for a colon primary site, C180 to C189. Remember when we talked about the SSDIs for the radial margin, this is coded as a procedure in the surgery field, but do not consider it a resection for the radial margin, even if the pathologist gives you a radial margin. We're not taking that information from a polypectomy. Pictured on this slide is the removal of only a segment of the colon. So in this example, it's a transverse colectomy. And since the tumor is located here in the transverse segment, you can see they've only partially removed a segment of the colon. So that would be a code 30 in the colon site codes. Now here's a picture illustrating a code for a sigmoid colon resection. It will also be coded a 30 for a type of a partial colectomy of the colon. This picture shows a right hemicolectomy and also illustrates how much colon has to be removed for a good colon cancer operation for a tumor mass in the ascending colon. This would be coded a 40. This is a very common procedure. Part of the transverse colon should be mentioned in the op report, and then you know it's not just a segmental resection, but it is a hemicolectomy. And then here is the reverse, the left colon resection for a mid-descending colon tumor. Notice again that part of the transverse colon is removed. So this would still be coded a 40. Here is a total colectomy. This would be coded a 50. This is sometimes the case when you can see here this person has 2 primaries found in the colon. Code 60 would be used if a total proctocolectomy was done. This is a resection that would also include the removal of the rectum, as well as a total colectomy, and the resection margin would be down at this red line. For a rectosigmoid primary, you would have to go to the other site-specific surgery codes for this. You will need to look up resection or a rectosigmoid resection. This would be a code 30. So some of the other fields that we code kind of around getting the information from the surgery would be the surgical margin. This is a quality measure for path reports. It's used for staging, and it might be a prognostic factor in recurrence. The scope of regional lymph node surgery. These are the codes. Typically, there is not a sentinel done for colon cancer. Sentinel biopsies for the lymph nodes are usually done for breast and skin melanoma only. So you most likely will be using possibly a 1, but most likely a 4 or a 5. You would not use a 6 or a 7 for colon cancer. Surgery of other site. This would be if there was removal of distant lymph nodes or tissue or an organ beyond the primary site. This field is most often coded 0 for none, but for most colorectal cancer primaries, one example would be if there was a metastatic nodule in the liver removed. The key factor here is that the regional or distant site has to be removed, not just biopsied, and it has to be removed because it thought to be involved with cancer. So an incidental removal of a gallbladder or appendix would not be coded here because there's not a suspicion of cancer in that organ. Reason no surgery. There are some other reasons of why a patient would not undergo surgery. Maybe surgery wasn't recommended, or it could be contraindicated based on some other risk factors, comorbid conditions, and you can see you would code a 2 if surgery was not done for that reason. If a patient actually refuses surgery or a family member refuses surgery, you can use code 7 and be sure to text that information. Okay, so that's most of the surgery fields, and we'll move on to some of the other treatment fields. So radiation therapy is used mostly for rectal cancer, and oftentimes there's less surrounding organs to be affected by radiation therapy. So preoperatively or neoadjuvantly, they can use radiation therapy to reduce the risk of tumor, to make inoperable cancer become possibly a candidate for surgery. Or post-op would be adjuvant. They can use radiation therapy after surgery when there might be lymph nodes involved, or if the surgical margins might be involved, and they can give radiation therapy just kind of to give a little bit of an insurance policy that they can kill the rest of that tumor. The phases for radiation are collected by SHRI. These data items identify the radiation modality administered during the first, second, and third phase, respectively, or radiation treatment delivered during the first course treatment. So all three phases are considered first course therapy. The modality reflects whether a treatment was external beam, brachytherapy, radioisotope, or other combined modalities. The radiation sequence with surgery is a new field, but we've been collecting a similar field for chemo and radiation sequence. So it follows the same pattern. And then reason no radiation also has fields for if a patient did not receive radiation as part of the first course therapy. There are fields that you can, or codes that you can select for that. Looking at the radiation phases, like I mentioned, we're capturing the radiation treatment modality, and these forms of modality are listed here. And here in this SEER manual is where you will find the information on phases 1, 2, and 3. The in-depth codes for the COC program are found in the STORE manual for all of the other fields that you collect for radiation therapy. For SEER, we only collect the phases. So what is a phase? Phases are first course therapy. They're not subsequent therapy. And all of the phases are inclusive of first course treatment only. Radiation treatment is commonly delivered in one or more phases. Typically in each phase, the primary tumor or tumor bed is treated. So a phase 1 may be called the initial plan, whereas phase 2 or phase 3 might be referred to as a boost or a cone down. A new phase begins when treatments should be summarized in a separate phase. If they are directed to a different body site, a change in the target volume of that body site, or a change in the fraction size, modality, or the treatment technique. So if you think about when to start a new phase, if a different site is being radiated, if there's a different volume or a change in volume or a change in the fraction size, these would be all reasons to start a new phase. So phase 1 treatment would include the treatment volume of the first course of therapy of radiation. It might include the primary tumor or the tumor bed. It could be regional or distant site that was targeted. It could include draining lymph nodes targeted during the first phase. And this information comes from the radiation oncology treatment summary. Here are the codes for the treatment modality administered during the first course of radiation. Radiation modality reflects if a treatment was given externally, or brachytherapy, intracavitary or interstitial, or if it was a radioisotope. Okay, moving on to chemotherapy. 5-FU is a common drug. Some of the other common drugs are listed here, but with the initiation or the manufacture of all of the chemotherapy and immunotherapy that has been done now, and even the genetic drugs, it's almost impossible to keep up with every form of treatment. But mainly just to remind you to keep using SEER-RX. That is the best source of information that we have for correctly coding the drugs that you're seeing. And even if you're not sure if it's a treatment, go ahead and look it up or Google it and get an idea of what the drug is. So just a quick look at SHRI, and I put leucovorin in here mainly because that used to be a drug that was commonly given with 5-FU. It is an ancillary agent, so if you had 5-FU leucovorin, you would code a single agent for a chemo because leucovorin is not considered any kind of category that we report or record for treatment. It is ancillary. Looking at the chemo codes, and this is from the SEER manual, these two-digit fields are where we would code, like if they didn't have chemo. O2 would be if there was just one agent given. O3 would be multi-agent. If you look at the description for 82, this was not, chemo was not recommended because of comorbid conditions or other medical problems the patient might be having, so that it would be contraindicated due to the patient. Going down to 87, that would be if a patient refused treatment or if the family refused treatment, and make sure you're texting that information clearly. If the patient has several things laid out before them and they opt for one kind of treatment and not another, that's not necessarily refusing chemotherapy or refusing a different treatment. It's called informed consent, where they have all of their options laid out on the table and they're picking one, so it doesn't mean they're refusing the others. Also, code 88, if chemo was recommended but it's unknown if it was administered, code 88 can also be used if the patient was referred to an oncologist, you just don't know the outcome, or if they insert a portacath at your hospital and you don't know if the patient went on to get chemo, you would code that to an 88. Okay, that's pretty much everything for treatment. Now I want to just briefly look at text documentation and a couple of specific things for colon cancer. So we want to support our codes with our texting, and it's especially important for the staging codes, like the extent of disease codes for the tumor and the nodes and the METs. The recommended method of abstracting is to text all of your information first and then go back and try to code from the text that you have provided. If there's something that you're trying to code and you can't get it from your text, then you might need to go back and add some more text to clarify that. Here are the typical text documentation sections on most cancer software. The surgery section, sometimes there are more fields. The surgical observations would be more like what is from the op report, what findings did they find, and then the path report obviously is from your pathology department. And then anything you can provide in the discharge summary as far as date of last contact or maybe where they got treatment, anything that is not related to their diagnosis, anything that is found during the workup and diagnosis would go up in the physical exam, but any other subsequent visits or oncology consults, radiation therapy consults could go down in the discharge summary diagnosis just to follow along with the patient. So in the physical exam, here are some recommendations of what to put in here. Again, just some basic, age, race, and sex, their chief complaint, a brief summary of what is going on with the patient. If there was a physical exam done, looking for any masses or blood in the stool. A lot of colon cancer patients come in with anemia, or if a digital rectal exam was done. Anything related to the colon cancer or a family history of colon cancer would be helpful, but any other history that the patient has really is not pertinent. If there's anything that was done prior to admission, say they had a workup done prior to admission and they come into your hospital for surgery. If you have a pre-op CEA, a pre-op MRI or PET scan, that information actually goes in the correct field, not up here in the summary section of the physical exam and history. So if you have a CEA done, either prior to admission or coming to your hospital and having it done, put that information in the lab section. Also remember to text the lab value and the interpretation or the range, and that is an SSDI, along with the KRAS and the MSI. This information can all be put in the lab section. Any scans or x-rays, PET scans, anything like that, whether it was done prior to admission or done at your hospital, can go in this section. Always make sure you're putting a date, and then you can put PTA for prior to admission, and then give us the results of that imaging report. Any kind of scopes that might have been done, a colonoscopy, sigmoidoscopy, any kind of a biopsy of the liver, anything that was manipulative or exploratory goes here in this section. And then, of course, the surgery or the operative findings with the date goes here, and the name of the procedure goes here, and then any kind of findings as far as where the location of the tumor is, the extension of the tumor, if there's lymph nodes involved or other organs, or if they're not, and the surgeon puts in his op note that those are all normal, it's still important to put that information in your text. And the path report is pretty self-explanatory, making sure you include a date and the type of the specimen that you have, and then give us the final diagnosis. Make sure you have the addendums, make sure you have the CAP summary. If part of the information is in the final and clearly a lot more information is in the CAP protocol, you do not need to repeat information. You just have to put it in the path section once. And then the remarks area, this would be a good place to put the last data follow-up, any comments on the discharge summary or the report, any future plans for treatment, maybe they got discharged to another hospital, and date of last contact. And I see I didn't have on here the staging text field, but when you're putting the staging in, like a TNM from a path report, start that with date, and then maybe a path or path report TNM. And then if you have another one that's by an oncologist, the date, the TNM by oncology, so that as the editors are looking through your abstract, if the TNM is done by a physician, we will use that information to help with the extent of disease and some of the other fields. But if it's done by a registrar or not labeled as done by a physician, we do not use the TNM in editing. I've listed all of the SEER Educate colon exercises here, and my contact information is below. Feel free to let me know if you have any questions, and thanks for listening.